Hi, my name is Sarah Abusi, internal medicine resident at Orlando Health. I'd like to share a case of localized cervical amyloidosis with an unusual clinical presentation, position-dependent syncope. Our patient is a 63-year-old man who presented with recurrent episodes of syncope that were consistently triggered by turning his head laterally. At the same time, he had developed a progressively enlarging left-sided cervical mass. Initially, the two findings did not necessarily seem connected. The cervical mass had been treated as presumed lymphadenitis, but continued to enlarge. Imaging eventually revealed a large mass encasing the carotid vessels with significant narrowing and displacement of the carotid artery. The clinical picture began to come together when we recognized that the patient's syncope was reproducibly associated with neck movement. An extensive syncope evaluation did not identify a cardiac or neurologic cause. This made the relationship between the cervical mass and the patient's symptoms increasingly difficult to ignore. The mass was located directly around the carotid bifurcation, making carotid sinus compression a plausible mechanism for the position-dependent episodes. Mechanical stimulation of the carotid sinus can produce an exaggerated autonomic response, resulting in transient hypotension, bradycardia, or both. However, the underlying diagnosis of the mass remained uncertain. The differential included lymphoma and other cervical neoplasms. Tissue ultimately provided the answer. Ultrasound-guided biopsy demonstrated Congo-red positive amyloid deposition, with mass spectrometry confirming AL amyloidosis. The pathology is particularly striking. What made this case especially unusual was that the amyloid was localized. There was no evidence of systemic involvement on the extensive evaluation, supporting a diagnosis of localized cervical AL amyloidosis rather than systemic AL amyloidosis. The anatomy also explained the physiology. Because of the extensive vascular involvement, complete resection was not feasible. The patient therefore underwent surgical debulking. Following the procedure, his syncope completely resolved. This case highlights several important lessons. First, localized amyloidosis can present as an unusual mass and may mimic more common cervical pathologies. Second, the physical relationship between a lesion and a reproducible symptom can provide an important diagnostic clue. In this patient, the positional nature of the syncope directed attention toward the carotid sinus and ultimately toward the cervical mass. And finally, localized amyloidosis should remain in the differential when tissue demonstrates amyloid, even when the evaluation for systemic disease is negative. The patient turned his head, the symptom appeared, and the anatomy explained why. That is what made this case so unusual and why we titled it Fating on Cue. Thank you.